I'm a bit nervous because I'm an anaesthetist talking about measuring GFR to a crowd of nephrologists. I think it must be a bit like a nephrologist teaching anaesthetist about intubation. The reason I'm here to talk about MGFR is because I've been working with a company who are developing a technology to measure it. So I need to declare that conflict. Fast Biomedical is the company. I am going to talk briefly about a competing technology as well in order to provide some balance. So here we go. So let's hypothesize that one of the reasons why we have not been able to translate effective therapies in the preclinical situation is because we have a lack of diagnostics or theranostics that facilitate that process. And to illustrate that hypothesis, I'm going to ask you, where would the large cardiology trials be if they didn't have better diagnostics? And why is it that we haven't got good quantitative diagnostics in nephrology? And in order to answer those questions, you need to accept, if you will, my thesis that we don't have good quantitative diagnostics. I'm going to try and show you some work which we've been doing to try and improve that and to try and explain where I think it will fit in our testing armamentarium. Let's look at some of the primary outcomes we've been talking about over the course of the last couple of days in the context of acute and chronic renal disease clinical trials. Death, fairly easy to adjudicate. Dialysis, incidence, duration, but dialysis can be a subjective sport, as you all know. What about permanent or sustained loss of kidney function? How can we measure that? Well, GFR is a physiologic measurement, right? It is not a surrogate marker, although some people will tell you it is. And it is perhaps the best global measure of kidney function, or at least kidney clearance function, that we have. Obviously doesn't speak to the endocrine function or any of the other homeostatic functions of the kidney. But nevertheless, a way of measuring GFR instead of estimating it might represent at least a small advance. So why have our clinical trials been unsuccessful? Early diagnosis of AKI, as you know, is difficult, and quantifying its severity is near impossible. And I say that despite the work of my friends and colleagues in the rifle, akin, and KDIGO world, who have done a really good job of quantifying it to the extent that we can, although I think even they would agree that it is an imprecise art at best. In order to increase the event rate and find signal, we study high-risk patients, which means we learn nothing about low-risk patients. In other words, we study the tip of the severity iceberg, and then we try and infer that less severe disease is also relevant. And I'm not so sure that that's a safe assumption. Our primary endpoints, therefore, lack sophistication and sensitivity. As I said, dialysis is subjective at best. eGFR is very insensitive to acute changes in renal function, and clinical scoring, by definition, has to be retrospective. We lack an ability to quantify function at the individual patient level. So let's ask ourselves, why is measuring GFR important? And I think we were getting into this in the session immediately before this, is because the most important determinant of clinical outcomes in AKI and CKD is the extent to which we lose clearance function, to which we lose GFR. And neither serum creatinine nor eGFR can give us a reliable measure. So humour me and consider what glomerular filtration rate is and what it's not. So GFR varies throughout the day. It's not constant. It changes in both a saccadic fashion and also in response to what we eat and drink. When we collect a 24-hour urine for a creatinine clearance, of course, that measures the average daily creatinine clearance. It's not sensitive to things that change during or in the moment. And as you know, if you work in the ICU, things change in the moment all the time. What about renal reserve, this tantalizing concept that we're beginning to be able to access through protein load testing, and we were talking about that in the session before. It's that portion of GFR that can be stimulated over and above a patient's baseline renal function. But let me ask you this as a nephrologist, when we lose GFR because of an injurious process, do we first lose renal reserve and then our baseline GFR, or do we lose them in proportion to each other? I don't know that we know that. I think we believe that we lose them a little bit in proportion, but no one knows that for sure. So which GFR then is more sensitive to loss with AKI? Is it baseline or is it total? This is a very well-known figure. It relates declining GFR to increasing serum creatinine in men on the left and in women on the right. And as you know, it is easier to find a decline in GFR if your starting GFR is low because of the relationship that this curve depicts. In the sensitive area over on the left-hand side of the curve, there's a much greater increase in serum creatinine for any given loss of nephron mass than there is over on the right-hand side where the GFR is normal or preserved. And by inference, extending that curve out to the right is the area of renal function that we call renal reserve that we try and get at through protein load testing. Here is a graph of the amount of GFR that you have to lose at different baseline creatinines in order to cause a 0.3 milligram per deciliter rise or to trigger AKI stage 1. So the higher the GFR, the more severe the injury it takes to show that serum creatinine elevation. So question number 2 for you, are CKD patients truly at higher risk? Or is it just that our relatively insensitive tools are able to detect a change in GFR with improved sensitivity in those patients who start off with a lower GFR? Well, what do we know about renal reserve? Well, we know that it's mediated by vasodilation and increased effective renal plasma flow with a stable filtration fraction. But the mechanism of that increase in ERPF is unknown. You can initiate it by administering animal protein, amino acids, dopamine, glucagon, and they say you get a maximal response about 2 hours post-meal or infusion. Now, we don't do this in our peri-op medicine clinic, but I'm increasingly persuaded and starting to think about maybe we should. The problem is the response is unpredictable. And here is an old study from '94 showing the percentage rise in GFR for any given baseline GFR. It's a completely random process. So we don't know who is likely to develop a high measurable increase in GFR in response to a protein load. Wouldn't it be lovely if there was a test that could access that reserve information? So why do we need to measure GFR instead of estimating it? I think the answer to that question is because of this concept of the improved predictability of who will develop AKI if we were able to measure baseline renal reserve a little more accurately. It would allow us a more sensitive way to quantify both short and long-term loss and recovery of kidney function in both AKI and CKD. So the current state of the art is clumsy at best. I've tried to make the case for why. I'm going to spend a few minutes telling you what we do currently and then hopefully showing you a couple of interesting new technologies which are on the way and will be available soon. So we know that serum creatinine is a poor indicator of renal function in both the dynamic and the critical care clinical setting. There are other approaches to measuring GFR, such as iothalamate and iohexol, but they are difficult to use and they're not widely clinically available. It's not available to me routinely, for example. Cumbersome, expensive, and time-consuming. Takes 6 hours plus some more analysis. So a rapid bedside MGFR technique would enable early identification, follow-up of kidney injury, quantification of drug dosing in oncology, for example, in-the-moment management as opposed to assumptions on a daily or worse twice daily basis. How do we measure GFR now? There are multiple gold standard techniques. I've talked a little bit about creatinine clearance, which is probably the most widely used, 2, 6, 24 hours, depending on whether or not you believe they're cross-referable. Inulin, iohexol, and iothalamate, but all of these tests require multiple visits to the bedside, multiple blood draws. Some of them use radiation or contrast. They're all based on a single compartment model of the ECF, which is probably not true. And of course, in the moment, in the ICU setting, GFR changes. And we still don't know which GFR should we measure: stimulated, baseline, or average. So a couple of techniques that are coming to the market soon. I'm going to talk to you about the first, which I don't know very much about, but I include for balance, is made by a company called MediBeacon. This is a fluorescent technique involving the injection, I believe, of a single fluorescent marker, and then it is measured using a transdermal optical detection technique. And the basis is that the injection of the marker disperses throughout the circulation and then is cleared through the glomerulus in an entirely predictable and measurable fashion, giving you a measurement of GFR. It's been described and validated in multiple papers, mostly in the clinical chemistry literature, which is why it may not be familiar to this crowd, but I think is promising, and I know that some in the audience are involved with the development of this technology. In a similar vein is the technology that I am familiar with. This is made by a company called Fast Biomedical. They are developing a combination fluorescent marker technology to measure both MGFR and plasma volume simultaneously. And it too uses the same concept. If you inject a small volume of a known concentration of a marker, it can then disperse throughout the circulation, and the new concentration as it's measured gives you the plasma volume. It's the differential clearance of the small and large marker across the glomerulus which allows them to measure GFR. So I'll show you some data from this technology, some clinical data in 90 patients studied in a couple of 2 or 3 phase 2 clinical studies. These experiments were done in Germany and in Alabama and Texas, including both healthy volunteers and patients with stage 3 and 4 CKD, including comorbid disease such as hypertension, diabetes, and chronic obstructive pulmonary disease. So the visual fluorescence injectate was well tolerated in everybody without any evidence of a safety concern. 4 cohorts of patients, each with 8 subjects in each. The first 2 in normal renal function, or at least a screening EGFR greater than 60. The first cohort was a single dose looking at correlation with iohexol, and the second cohort in normal subjects was looking at reproducibility on day 1 to day 2. The third and fourth cohort looked at patients with EGFRs between 30 and 60 mils per minute per 1.73 meters squared and 30 and 15 respectively, in order to try and get a sense of, do the changing or the different kinetic situation in CKD patients affect the technology's ability to measure GFR. There were patients ranging from 19 years old to 79 years old, males and females, white, Hispanic, African American, and in weight ranging from 58 to 147 kilos. So quite a nice dispersal of body types, shapes, genders, racial backgrounds, and quite a wide variation in EGFR from 20 all the way to 135. And this is the correlation plot with CKD epi estimated EGFR. Pretty good, I think you'll agree. And importantly, it's pretty good in the 100 to 140 range. In other words, where the current techniques for estimating GFR are not good. And I think that's one of the exciting aspects of this technology. Correlation with, what did I just show you? Yes, that's correlation with estimated GFR. Here's correlation with another gold standard measurement of GFR in iohexol. Again, I don't think you could really expect much better clinical data than this in these 90 subjects. The repeated cohort, this is cohort 2, highly reproducible from day 1 to day 2. And these data have been published now in JASN this month. Dana Risk and Bruce Monitoris wrote these data up and published them, as I just said, in JASN. So in summary, I've tried to make the case that we need better tools to do our work. We need better equipment, better methodology, because our patients deserve it. We are lagging other specialties in our ability to measure and manage our disease process. We cannot expect our clinical trialists to deliver effective therapies if we don't have tools for them to measure their outcomes. Serum creatinine and EGFR are of limited value. They have a huge installed user base. I'm not suggesting for a moment we should throw them away, but we need to improve on them and enhance them. I like this concept of renal reserve, and I'm interested in finding ways to access that information a little more easily than the current 6-hour protein load, starve first, come and see me in the clinic model. So MGFR is here. It's coming to a clinic near you soon. There are multiple companies developing technology, and that's a good sign because it means that multiple private equity companies think it's a good idea, which means it probably is. So this technology will come to the market, and I believe the race is on to get there. In conjunction with plasma volume measurement, those of us in the ICU are looking forward to a day when we'll have more accurate volumetric measurement and more active functional measurement too. Thank you very much.